Kia ora koutou. Welcome again to a lunchtime webinar from Mobile Health. It's my pleasure to introduce Deborah Bush today as your speaker. And Deborah is going to be talking about endometriosis, a public health issue that's too big to ignore. Deborah has had a global influence on the promotion and prevention of endometriosis worldwide. She developed the world's first menstrual health and endometriosis program for schools in 1997, which has significantly influenced early recognition of symptoms and timely intervention in adolescents in New Zealand. And this has been endorsed by the World Endometriosis Society as the preferred education program worldwide. And I know Deborah's got a full program to offer you, and without any more delay, I'm just going to welcome her and invite you to start, Deborah.
Thanks very much, Pauline, and thank you for the introduction. Kia ora, everyone. It's really nice to be here and speaking to you in this lunchtime seminar. We've got a really big program to get through today, so I'll just explain what we're going to do and go over. I'm going to divide this into chunks so that we work through the things that we need to get through and hopefully leave some time at the end for your questions. It's a big topic and it's a big health issue, so let's get underway. Some of the things that we'll be covering: background, etiology, the diagnosis, patient's journey, chronic pelvic pain, treatment and management. I want to also introduce you to the new clinical pathway, if you don't know that already, early intervention, and also look at a few little patient vignettes from our clinical case studies. The background of endometriosis. So we're just going to spend a small amount of time having a look at the huge nature of this disease. So firstly, it's not a new condition. This is a painting in the Rijksmuseum in Amsterdam called The Sick Woman. And I think when you look at her, you probably think, with everything else that's going on, she's probably got endometriosis. That's what I thought when I first saw it anyway. But some of the things, well, we've known about it for a very long time, going back BC, and that it's now known as endometriosis, but it was first described by that in about 100 years ago by John Sampson. So it's not a new condition. It doesn't discriminate. I think this is a really important one for us to remember. We've heard many things. It doesn't affect Māori, it doesn't affect Pacifica, it may not affect African women or Asian women to the extent it does in European women. That's a fallacy, and I think we need to learn that really quickly and understand it. Nor does it exempt people who are very young because of their age. 1 in 10 is the prevalence of what we go on, but an Australian study last year, they showed that the prevalence was more like 1 in 9. 176 million women worldwide, so the research tell us. In actual fact, with the population growth in the last 10 years, it's more like 200 million now, and 120,000 New Zealanders with the disease, with our population growth now more likely to be beyond even 130,000 with the condition in this country. Some of the important facts about it and how it impacts for productivity and absenteeism, it's about 11 working hours per woman per week of that, and that's a global study on endometriosis. But more recently, the EY report from 2019 suggested around about 8 billion in Australia, and extrapolating that down, it's around about 2 billion in a public annual surgical and medical health spend in New Zealand. And I'm really pleased that we've just underway as part of a research product looking at endo cost in New Zealand. Looking at the burden per country, you can see that we're pretty on par with what it costs in the rest of the world. But if we look at this, this is a 2012 study, so we're almost 10 years down the track. And there it is there with a 7.4 billion spend in Australia from the EY report. and about 2 billion there from New Zealand. I think it's also really good for us to have a look and say, why am I banging on then in the news and in the media at the moment with government with not being able to implement the new clinical pathway as it was first designed, and all that work went into? We'll look at that in a minute. But when we look at patient experience, we ask some questions of our patients, and we said, how many surgeries have you had? Was it public or private, and are you well now? You just glance down the slide and have a look and see 17 laps, 8 laparoscopies, 5 all in public, 25 a mix, 5, 2, 4, 1 lap, and the general consensus is what now? Now that is pretty indicative of what we see on a daily basis dealing with tens of thousands of patients as we do through the organisation. It has a significant impact on relationships, on career, education, quality of life, fertility, and the physical, emotional, mental, social, and financial well-being with the fiscal spend. And I think with your patients, you'll be able to think of many who say they're just sick and tired of it and they've had enough. Moving on now to the next chunk in our presentation, we're going to have a look at the etiology and some of the other aspects of endometriosis from a physical point of view. So how do we describe it? The classification of endometriosis is also under review with our team from the World Endometriosis Society. But what we're describing it now as is an inflammatory gynecological tissue, where tissue similar to the lining of the uterus is found outside the uterus where it shouldn't be. I think that word similar is one that I've highlighted because it is not the same as the endometrium. And we come unstuck if we continue to say that because the research tells us otherwise now. Having a look where it affects, so mostly the pelvic organs here, the bladder, the pouch of Douglas, the bowel, the peritoneum, and other structures in the pelvis. But interestingly too, there is only one other place in the body that endometriosis has not been recorded in the literature, and that's the spleen. So I think we also need to have our ears open for patients who present with maybe cyclic pain or symptoms in other places. And one of the most common sites for endometriosis outside the pelvis is diaphragmatic endometriosis. It's clinically staged as 1 to 4, or 1 being mild and 4 being severe. And there is no correlation to the degree of symptoms along that spectrum. That's also really important for us to know as well. And we're going to have a look at that later down the track when we observe some photographic evidence from laparoscopies. So let's have a look at some of the symptoms. And I think we also need to be acutely aware of what our patients are telling us. In the first block here, the things that we would expect with endometriosis. So pain with periods, dyspareunia, lower back pain, bladder symptoms, subfertility or infertility, all things that we are very aware of. And the next lot, PMS, tiredness, headaches and migraines, pain during ovulation, heavy or irregular bleeding, and this next one, bloating, constipation, diarrhea, or IBS type symptoms, particularly when they're cyclic, but not necessarily. Now, these things are all really important as GPs to understand, because if we silo these symptoms and not think about them holistically, when we're not listening to the patient's story and acting for them. And I'm just going to draw your attention to this tiredness one as well and get some information from Professor Neil Johnson on that later on in the presentation. So also let's have a look at this differential diagnosis between primary dysmenorrhea and secondary dysmenorrhea and the different things that we might expect to find. So when does it normally occur? well, any time from puberty. We normally get pelvic or abdominal pain associated with the onset of menstruation, and that's pretty much the same from in secondary dysmenorrhea. The same with the symptoms. Only in secondary dysmenorrhea, we're now also starting to see other gynecological symptoms such as dyspareunia, whereas that may not be a youngster, a very young teenager might not be symptomatic with that. But she may have difficulty using tampons. So that's also worth asking the question. With primary dysmenorrhea, there are generally no abdominal findings on examination or tests, whereas that may differ in secondary dysmenorrhea, where you might, for instance, feel nodularity on pelvic exam. You might get indications from a scan that there may be some abnormalities that require referral to a gynecologist with expertise in endometriosis. Generally, with primary dysmenorrhea, a scan and other tests will, there are no remarkable findings, but that does not mean that endometriosis is not there. We're going to have a look at what that means in a minute. The global prevalence of dysmenorrhea is generally between 45 and 95%. It's huge, isn't it, in the female population. Here we are at laparoscopy. So this is Laura. She's 15 years old. She had stage 1 endometriosis diagnosed at laparoscopy. And we'll just have a quick, for anatomy's sake, just a quick having a look there. And of course, the bladder is up here. To all intents and purposes, this looks like an entirely normal pelvis. And in fact, was Laura's second laparoscopy. She went to the second laparoscopy after in fact, the first one proved negative, and her grandparents funded her to be able to go to someone with expertise. Endometriosis was found 3 months later, in fact, in the form of an inflammatory area in the ovarian fossa, and also another inflammatory area in that area of the pouch of Douglas, just sort of hiding in under here. Now, this was significant enough for Laura to develop mental health issues that no one believed her symptoms were real. She actually underwent some quite intense mental health therapy between the first negative laparoscopy and the second one. And she lost a lot of self-confidence, and well, she was a dancer and a netballer and doing well at school right up until puberty, when she did get her period. So her presentation was, of course, dysmenorrhea and chronic pelvic pain. We're going to have a look now at Lisa, who had stage 4 endometriosis, and her presentation of symptoms was infertility and chronic pelvic pain. A quick look at anatomy. My cursor is currently on the uterus there, engorged ovaries with large endometrioma on each side, a large plaque of endometriosis there on the bladder, enormous amounts of adhesions between the bowel and the ovary. In fact, one could almost assess this as a frozen pelvis. I'm pleased to report that Lisa did go on to have a 2-stage laparoscopic procedure, and was able, after this surgery and after this severe endometriosis, to have 2 children conceived and born naturally. I'm going to ask you a question in your mind. Who had the worst pain, Laura or Lisa? And I can't see you, but I hope you're making your mind up in your head about who had the worst pain. Now, Laura had no findings on scans. Lisa did have findings on scans, and that's why she was sent for referral. So who had the worst pain? And for those of you who have come up rightly with "we can't see pain, so we don't know," are absolutely correct. It would be very easy to go down the line that Lisa had the worst pain, but that generally isn't the case. Laura was absolutely compromised. She was unable to go to school. Her pain wasn't just cyclic, it was starting to become there on most days, so developing into that chronic pain condition at such a young age. Something, of course, we need to keep in mind. So no, we can't see pain. We don't know who had the worst pain. Lisa had severe disease. Laura had mild disease. So the question is, can we stop this from becoming this? And we think we can with early recognition of symptoms and timely intervention. And so let's move on now in the presentation and see what Michael East says about these diagnostic bell ringers. And this is particularly helpful for you in GP practice. Mr. Michael East says that menstrual distress is always abnormal. Mid-cycle distress is as well. Pain with defecation, always abnormal. The next one, always abnormal. Pain with sex, always abnormal. Pain predating menstrual flow and localized dysmenorrhea, be suspicious. These are great take-home messages for you in your practice. Please be suspicious that these things are not normal and shouldn't be normalized. And while we can't conclude that all of these things are endometriosis, if your patient is suffering, then we must do something about it. So what does the patient's journey look like? So moving on now to the next chunk in our presentation. And sadly, it looks a wee bit like this. It looks a wee bit like I'm going to start here and this is where I expect to go. And I really want someone to tell me what's going on. And I want it to stop. But we tend to go around the corner and off on a different tangent and start again here and go in here. And actually what tends to happen is that patients, their story is often not heard. And with Easter coming up, I thought that this might be appropriate for the presentation. Furthering on from the patient's journey, I've simply taken now the logo of Endometriosis New Zealand, flipped it up the other way, and we're going to look at the patient's journey from this perspective. And everything I'm going to present along the journey is, of course, embedded into the literature. So let's have a look. We've got a patient and naturally she wants to be well. And these are patients you're seeing every day and you want to fix them. So often a patient's first port of call might have been the pharmacist. That might be something that you may not have seen, and she may have tried something that has been recommended to her. We know from the literature it takes around 4 to 5 visits to a GP to get to be heard and onto the next level. And in that time, she might have been given some medical therapy and some tests, and you will know what they are. And quite often that looks like an oral contraceptive pill. It may look like some scans and bloods, all good things to do. But if they come back normal, it might be the red herring that we don't need in this case. And often what has been found is that it's a bit hit and miss. And the diagnosis is a bit hit and miss. And maybe that too requires our patient education as well. Because if they're mainly presenting with bowel-related symptoms, you have 10 minutes, you're going to be maybe skewed off in that department, but asking a few extra questions about their menstrual cycle and whether those symptoms are worse with that would be a good idea. She might see a specialist. Finally, she gets to a gynecologist. Endometriosis is diagnosed and it's treated. And we're going to go into treatment a little bit more in a minute. But before we do, I just want to draw your attention. So I've got my cursor and I'm going from here to here and asking you in your mind if you know what the diagnostic delay with endometriosis is from first presentation of symptoms? And I'll quickly give you the answer. It's 8+ years. Now, if in anyone's book, that's a long time to be waiting in a queue. And you could see from that presentation, one of the earliest slides, when how many laparoscopies have you had and what has the delay been like? Some of those women who responded to that, it's been 25 years. They were a 13, 14 or 15-year-old on first presentation, and they're in their 40s at diagnosis. You know, we need to do something about that, and it is urgent, and it is a public health issue that we simply can't ignore. So what happens here? Because in any right kind of journey, we would expect that things will have resolved. But many of our patients, particularly those who have developed chronic pelvic pain, pain on most days that's lasted longer than 6 months, are not naturally going to be well. So assuming now, well, you've had your surgery, this is really annoying, she's not responding. It's understandable. So what do we need to do? Well, best practice treatment tells us that a multidisciplinary approach is best practice. And we need to look at what other causes might be contributing to her not actually having the outcome from surgery that we would have expected. And so we need to have a look at pain assessment and managing that pain. Now, as part of the patient journey and patient education, which I'm very involved in, I'm also going to be looking at here education and looking at nutrition. And if their bowel symptoms still remain, we've got a very grumpy pelvis. And why are the neighbors in the pelvis all grumpy? Well, they get grumpy over time. And so that might be pelvic physiotherapy and assessing those pelvic nerves, pelvic muscles. Is the pain radiating from the hip? Could it be the obturator internus that's in spasm? And looking at diet. Now, there is no endo diet, but there are foods which seem to exacerbate the bowel-related symptoms, and they're largely the FODMAP foods. And I'll show you where you can get information about that towards the end of the presentation. So moving on, exercise is the best non-drug treatment for pain. But telling someone who's crippled in pain and doubled up on the couch with a hottie to get out and exercise is a difficult one. We should be starting really, really gently. And in fact, what it tells us is that the literature tells us is that chronic pelvic pain, a traumatized pelvis, doesn't do so well with rigorous exercise. Gentle and regular is best as we work up to something that is perhaps going to be more suitable. But exercise, being mobile, we all know that it's good for every chronic condition. Other therapies, and of course there are many other things that are advised. We work on the ones that are evidence-based, as I'm sure you do. And mindfulness, what we're finding now is what are the mindfulness techniques that we can use in these chronic pelvic pain patients to assist them to be part of their multidisciplinary management. I don't want us to ever forget the undiagnosed patients and the burdens that creates for them mainly, but also in our health arena. So here's a few of my patients that I see, and I've just selected one from a teenager, one in their 20s, 30s and 40s. Let's have a look at this. So when was the symptom onset? Well, at 9 for our 19-year-old. She had a diagnosis at 17. That was 8 years, about average. She's had 4 visits to a GP. She's seen 2 gynecologists. She's had 1 laparoscopy. She's living with day-to-day pain that impacts her work and her study. She doesn't know what she wants. She's over it. And if we go through the rest of these vignettes, we can see that the diagnosis was 17 for the next one. That was a 5-year delay, 4.5 years of doctor's visits. look at all the things that she has tried. Her current situation is symptom-free. She's extremely lucky that she had health insurance, and all treatments are through the private health system. But here's the thing, and this is something we must not forget with our patients, and that's that she wants help to get over the anger of being disbelieved for over 4 years, and help to relieve her anxiety about her future fertility. Now, that's a big one, because one of the things that we'll often ignore is the impact of this disease on mental health. And I'm going to address that shortly. What about our 31-year-old? Okay, she had a diagnosis at 21. Symptom onset was at 16. So she's seen 2 GPs and 3 gynecologists and 4 counsellors and 2 urogynecologists. And so it goes on. You can read the line yourself. And the next line. Current situation, she's currently pain-free. She conceived naturally after 6 years. She has ongoing IBS. She wants help to re-engage with relationships and dietary advice. So it's not all about the next surgery or what drugs can be delivered. And what about our 40-year-old? There was a 12-year diagnostic delay there. And you can read yourself about the number of surgeries and the number of people and health professionals she has seen. Current situation is that she has total suppression of ovarian function. She has pain 15 days a month, approximately. She would like help to manage her pain around her full-time job and family, and actually ways that she can articulate about what it's meant to her. So let's now move on. And I'm sure some of those patient vignettes are really applicable to patients you know in your own practice. I want in this slide for us to have a quick look at chronic pelvic pain. And of course, this can apply to any chronic pain condition. In this case, we're talking about endometriosis and pelvic pain. And of course, we need a driver of the pain. And in our case, it's the pelvis and the organs in the pelvis and the muscles and the nerves. So let's have a look. In any situation, we've got messages going to the brain, of course, that there's pain. And the brain will let those organs know, yep, I got that. And so this is what we're often referring now in chronic pelvic pain as central sensitization. If we have a look at what this means now, though, in terms of its impact on patients, all right, they're well-known organs. And it's also, remember, we went back to our classification. We're describing endometriosis as an inflammatory condition. So we've got to remember that inflammation plays a marked influence on pain. So this patient, it's all I think about. I try to let people know how bad it is. Most people don't get it. It's hopeless. It's affecting everything, my life, my sleep, my sex life, my friends, even my fertility. In fact, now I hardly even go out. It affects my mood. I'm anxious, I'm depressed. I now have other pain conditions. My whole body feels like it's on red alert. I've got nausea, I'm dizzy, I faint a lot, I get burning pain. Of course, we know that is related to nerve pain. I'm bloated, normal sensations become painful, and the pain is increasing. When we have a look at this, it is safe to say, and from the literature, that chronic pain is chronic stress. And why we must do something about this. Remember, 130,000 of our New Zealanders have endometriosis. So what is the treatment that is currently being offered and is suggested in the new clinical pathway? The first thing that we must do, and this is so important in primary healthcare, is recognize the symptoms and intervene early. be suspicious when you're hearing a story. I really encourage you to go and familiarize yourself with the clinical pathway. You will find it in the Ministry of Health website, buried under E. And then you will also find it on the front page of Endometriosis New Zealand website. It is specifically designed really to ensure we're managing it much better in primary health. So it really is, I do encourage you to go in there and familiarize what they're saying about medical management. First line is obviously non-steroidals, oral contraceptive pills. The clinical pathways suggest that they're progesterone rather than combined pills. But in very young patients, you might want to start with a combined pill and then move on. It's well described, and the reasons are well described in the clinical pathway. Looking then at maybe a Mirena or a JDS, depending on the age of your patient. Looking also at GnRH analogues, and but we know, of course, that they have or can have marked side effects. So bearing in mind those and whether you would suggest that they're a good idea, and it may depend entirely on the age of your patient and her needs. Opioids are sometimes being prescribed, particularly when a patient presents to ED, and down the track, she might have, by the tender age of 19, drug seeker on the top of her report. What we found is that, and the literature tells us, that opioids are not an effective medication for chronic pelvic pain or for dysmenorrhea, and that you will need to have a little bit more and a little bit more and a little bit more until the person is reliant on them and they're ineffective. The laparoscopic diagnosis and excision of disease. So in the clinical pathway, it suggests that a diagnostic only procedure is not advised. And that's because we should be, if we're putting a patient into surgery with a general anesthetic and the risks associated, we should be treating it. Excision is really the best practice treatment, and excision is removing, resecting, or excising the disease. Most gynecologists are not advanced laparoscopic surgeons, and other methods tend to be used. I would, something like cautery, for instance, or diathermy, I would certainly explain to the patient when you get the notes through from her surgery to have a look to see what was done at the time of surgery. What has been found is that's often just the tip of the iceberg, and that resection or excision is really, for want of a better word, gold standard. Then we have to look at this multidisciplinary treatment that we looked at before in terms of primary and secondary care and the kinds of things that you can do. Is your patient continuing to get this continual pelvic pain that isn't going away? And what other aspects can you refer to? Musculoskeletal assessment, for instance, pelvic physiotherapy, for instance, dietitian. For instance, I do well health coaching for well-being in my own private practice. So self-management, and I often think this is a really interesting one because we say, well, you know, practice self-management. So are we asking our patients to take personal responsibility for an incurable disease of uncertain etiology? Sometimes we are. And I think the outcome is that patients do actually respond really well, but we need to also assist them in the things that they might be able to do to self-manage those things. And a lot of them are we've referred to before. And with my patients, I'll often apply the 10% theory. So we look at saying, well, you're this much better from surgery. Now, how about if we pop in some other things? And all of a sudden they're at 80 or 90%, which makes them functional and at least happy to continue. So those are some of the things that I will allude to when I'm listening to their story to see how I can help. I think this one hopefully will also be interesting to you. So I've asked Michael East again to follow up some of the questions that have arisen in mobile services, CME, and other presentations. So he said, well, you know, the question was really, what are some of the non-steroidals you could use? And you can have a look at what Michael uses with his patients. Progesterone, as I was saying before, can be a bit of a trade-off, as most have side effects. So he's given you some ideas there, and they are also listed in the clinical pathway that you can go and have a quick revision yourselves. He's suggesting that if it robs people of their libido, then he would add perhaps 1 milligram of estrogen. Once again, we talked about the combined pill in very young women, and he is suggesting a transition down the track. The CA125 is a question that came up as a marker for endometriosis in previous presentations. And once again, it's not a diagnostic marker. It's not specific to ovarian carcinoma, but for monitoring or helping to diagnose ovarian carcinoma. It is often elevated in those with endometriosis, and Michael has suggested if it's over 35, you must refer for gynae assessment. Tiredness and fatigue. In a former slide, I said I would come to this, and once again, Professor Neil Johnson has given you some ideas here about iron deficiency and those women presenting with anemia who also have chronic pelvic pain or endometriosis or indeed heavy bleeding. So you can glance your eyes through the bullets on this slide, and hopefully that has been helpful to you as well. So in Professor Johnson's experience, he's saying quite a few clinicians, including himself, are endeavouring to screen for iron deficiency and borderline iron and treating that with infusion. The New Zealand clinical pathway. So here we go. In 2015, I formed the Task Force Working Group, and that included the Faculty of Pain Medicine, RANZCOG, the Royal College of GPs, Endometriosis New Zealand, Ministry of Health, and patients. So it was a good working team. It was not funded by the Ministry of Health. We funded that, and over 5 years before it was launched on March the 2nd, 2020, ourselves. And we're very happy to have it over the line, thinking it was going to be implemented. It is up to us at the moment to ensure that we're familiar with it and that we do our best in our own setting to make sure that we're following the guidance. And really, I've broken this down into some understandable format. We need to recognize the symptoms and signs and family history. And often there will be a family history, even though there's no diagnosis. Mum or grandma or somebody in the family may have experienced similar symptoms. Symptoms may be cyclic and accumulate over time. Normal physical exam and or ultrasound does not exclude a diagnosis of endo. And clinical diagnosis of endo can be considered within primary care and appropriate management. And I'll show you what the outcome of a study that we did shows you about that. So let's move on. You can manage in primary care. Dysmenorrhea may be improved, as we've said, from the clinical pathway. You can commence progestin therapy to inhibit ovulation. You can consider combined oral contraceptive pills if progestin therapy proves unsuitable, and call the patient back annually. In secondary care, refer to a gynecologist with expertise in treating endometriosis and following a multidisciplinary treatment approach if the patient has uncontrolled symptoms resistant to what you have managed to do for her. So why early intervention? Well, just to be clear, and I'm sure that I really hammered this home, but to make sure we all understand, primary dysmenorrhea, endometriosis is the leading cause, but of course not the only cause. Age of onset of symptoms, it's young. The disease starts young, often from a girl's first menstrual period or sometime in the teens. Diagnostic delay, the impact on fertility, the downstream costs, the potential for it to develop into chronic pelvic pain, and that can be very quickly because the literature and the guidelines say so, and because we have an obligation to provide a duty of care. And here's what we know with youngsters, that the global incidence of dysmenorrhea is high. There was a menstrual disorders or MDOT study of teenagers in Australia said that a quarter of the youngsters in that study had marked menstrual disturbance, which stopped them from going to school and participating in regular activities. So we went on with our ME program, or Menstrual Health and Endometriosis program in schools, and we did a study that was published in ANSJOG in 2017. And we found 27% of girls often or always miss school due to dysmenorrhea, more than a quarter. You know, we must do something about this. That's simply unacceptable that we've got more than a quarter. Now, in that study, there were more than 5,000, so it was a rather large cohort, and over 2,500 responded to the survey. So what we know about severe dysmenorrhea is that it has disruptive development, interrupted education, missed job opportunities, and the huge emotional, psychosocial, physical, and mental health outcomes are major. And I've said it, but we must recognize the symptoms early and intervene in a timely manner. There is no other screening tool. So education is in fact the best screening tool we have. And I'm going to show you with my private patients how I've seen a growth in youngsters presenting. So here is the published work, so the ME program, and the question was the endometriosis education in schools, and it examined the impact of that program on early recognition, suggesting endometriosis. The program, as Pauline said in her introduction, has been endorsed by the World Endometriosis Society, and you'll find more about this on the Endometriosis New Zealand website. It's largely been running in Canterbury, Nelson and Marlborough, for those of you from those districts, for 21 years. It's also, from those of you who are in Hawke's Bay, been going there thanks to the a fund and a philanthropic fund for 6 years. In parts of Auckland or Wellington for 4 years, but that's now stopped, and that was just a fund that we had for that limited period of time. So you will be seeing earlier presentation of symptoms. Now, this is just a poster. I'm not expecting you to read it. It's just showing you more about the study. What I do want you to have a look at is this graph here. We're going to come to that. I'll enlarge it in a minute, so don't bother sort of straining your eyes at the moment. Here's my patients though, and this is from Oxford Women's Health. And you can see that I've been running EP coaching since 2001. And I started keeping a track of the number of young patients that presented to me. So here we have, in 2001, 12% of the patients who were referred to me from the gynecologist for their well health and well-being session were under 20. You can see this trend line of the under 20s here really start to escalate, and by 2006 that was something we're going to come back and have a look at later. A little bit of a fall off, but in fact the trend line continues right up into 2015. I continue that at the end of 2019. At the end of 2019, the number of under 20s I saw diagnosed with endometriosis following their surgery was around about 62% of the overall age presentation. There's a drop off also, which I think is really interesting in this age group here. So the 21 to 25 age group. And just FYI, if you want to know where that great big ugly gap is, it was a whole set of earthquakes, and we had other things going on at that time. So let's have a look at this peak in 2006. Remember, please, this is a tertiary referral centre. So many of these youngsters had already tried oral contraceptive pills. They weren't doing well. So I understand that this is a biased cohort. Nonetheless, 96% of this group went on for laparoscopic review. Of the 96, 98% were diagnosed with endometriosis, and half had stage 1 disease. Now that's really interesting. And the presentation of symptoms, as we would suspect, no surprises: dysmenorrhea, lower back pain, bowel symptoms, bloating and fatigue. I think what we can assume from this is that it is not an indicator that we must send all those youngsters presenting with dysmenorrhea off for laparoscopy. That is not the message. The message here is saying, be suspicious that it may be endometriosis and manage accordingly. We don't have the resource to put them all through a laparoscopy, nor should we be. So that isn't the message, but the message is clear that if these symptoms are continuing, it's likely to be endo. And just a very quick look at that under 20 group, you can see that there's 7%. So there was even a few in there who had stage 4 disease. And of course, when we look at the 30 to 35 age group, we see much more stage 3 and stage 4 clinical disease. There are big gaps and that there are unmet needs. Pharmacists are often the first port of call. Treat appropriately in primary care and focus on outcomes which matter to the patient. Just recently, I saw a patient, for instance, who had was being referred for her 7th or 8th laparoscopy. And when I asked her what was important to her, what did she want, apart from the fact that she wanted it to go away? She wanted to lose weight, and she wanted to learn to be able to engage in intimacy with her partner without it hurting so much. Neither of the things that she wanted equaled another surgical procedure. I think we need to be really listening for those things. What do our patients want? What are her unmet needs? Refer to a gynecologist with surgical expertise and a special interest in endo. Educate. I'm so pleased that this is happening today. So thanks for attending. Some great little resources. Okay, so there's the pelvic pain free downloadable ebook. Hang on, I've written this book called Endometriosis and Pelvic Pain with Dr. Susan Evans. It's on its 6th edition. It's a great resource. Many doctors and gynecologists have it as part of their practice. It is available through Endometriosis New Zealand, and the royalties have all gone to the organisation. So there's the book. Let's have a look at where you can go. Now, this is a screenshot, so I can't take you in there, but I will show you where to get this help. So if you go into Endometriosis New Zealand, so nzendo.org.nz, and this is what the front page will look like. You'll see about how we help. Now, under how we help, you'll see ESIG, Ask an Expert. ESIG is the Endometriosis Special Interest Group. Gynecologists and allied health professionals who volunteer their time to the organisation as an advisory group. And we ask them questions, as patient questions, and they respond. This is a great resource for you and for your patients. So the files look like this. Lots of pink rectangles that are like your big filing cabinet of interesting resource, all written for patients to understand, but all evidence-based. This one, for instance, first one I'm seeing here, masculinizing hormone therapy in endometriosis, that was written by a mum whose daughter was transitioning and wanted to know whether the medications that she was being prescribed would help or hinder that gender transition process for him. You'll see nutritional supplements. Look, we're adding to this the whole time. Communicating painful sex, that was written by Dr. Hannah Blakely, clinical psychologist. So all of these files that you can see are written by gynecologists and allied health professionals to help those with endo. Here's one on Zoladex that you'll see, GnRH analog, anti-inflammatory diet, and so on. I'm going to leave you to go and have a play in there, but it's great. Here is the motto of Endo NZ: strength through support. Mā te tau toko ka whai kaha ka ora. You are more than welcome to contact me for more information. I encourage you to go to Endometriosis New Zealand. It's a big, grunty website, and it has massive amounts of information. So you just need to click through and find your way, but hopefully we've made it easy to navigate. And it's a great place for you, but it's also a wonderful resource to send your patients to. Telling them to Google endo when there are well over 30 million references to endo on the internet, you don't know where they're going to land up, whether what they're going to is evidence-based, and supporting what you are saying to them to support the New Zealand clinical pathway and your pathway for your patients. Thank you. And I think we've now got some minutes to have some questions.
Yes, you do. You do. We've got a question here for you, Deborah. Is there available a list of gynecologists who have an interest in endo in New Zealand? Living in more rural areas, who would be the best to refer to is not always known, but patients are always happy to travel.
Yeah, thank you for the question. If you go into, once again, Endometriosis New Zealand, look, the short answer is we do not have such a file of a hot and cold file of doctors or gynecologists. But what we do have is on our advisory board, ESIG I talked about. If you go to about how we help, about us, and scroll down, you'll see ESIG. And it's a great place. It's not a complete list by any stretch of the imagination, but these are all people invited by the Endometriosis New Zealand board and also its advisors to help with ESIG. And you'll find their profiles and you'll find a list of who they are. If someone that your patient wants to see isn't on the list, fear not. They probably are a gynecologist with a special interest. They're just not on ESIG, but ESIG is a great place to start.
Great, thank you, Deborah. Now, there's no more questions coming in, but you do have a few more minutes. So what I'm going to say to you is, what kind of questions do you often get that this group haven't yet asked?
That puts me on the spot, Pauline. Questions from things like from patients. I don't think my symptoms are bad enough. And particularly from young patients, oh, I'm only off school every other month. And one of the slides I remember that I've presented today, and I remember not going over it, is that one of the things that we say in the ME program is that discomfort is normal, distress is never normal. And so that never normal. If your patients are ever, young ones, in the sick bay or not doing stuff with their family or friends because of their period, that's never a normal period. Likewise, if they're having to sit at work with a hottie on their tummy or be, present but not really. So that's what we talk about lack of productivity. And they've come to you for a reason, but what we find is patients often will downplay their symptoms. And the other one is they get nervous about going ahead and having a laparoscopy because they've often put up with such a lot. What if nothing's found? And I think those two are things that we can allay their fears, validate their symptoms, and encourage them to follow the plan that you have for them and that follows what they want.
Well, thank you. Thank you. I remember in our talk before we started, you were also saying how important it is to validate what people are telling you, because so often they live with a feeling of not being heard or not being understood, and that's a similar kind of thing, isn't it? But
that is absolutely the case with endometriosis. We've heard it for centuries. We continue to hear it, that no one believes. And in fact, when we work with parents with children who are presenting with suicidal tendencies, or their mental health has become such a state that they find that their bowel symptoms diminish or are eased if they don't eat. So they've gone on to develop other complaints and other issues that impact them. And the best thing that you can do is to listen, to hear, to validate, and to get an action plan for them.
Now, I've got some more questions coming in. What exactly is the relationship between irritable bowel syndrome and endo?
So even with, we saw the photos of Laura and Lisa, and you could see that Laura had, the 15-year-old had huge bowel-related symptoms, in fact, been diagnosed with IBS. Look, the bowel is irritated for a reason. So we need to follow up on that. Now, sometimes the bowel gets grumpy just because it's grumpy with endo, and we don't fully understand why. We would certainly understand why with Lisa when we saw how the bowel was, it had plaques of endometriosis and deep infiltrating endometriosis into the bowel. It was all adhered with adhesion. So it's something that we don't fully understand, but it is probably second to dysmenorrhea and dyspareunia, the most common symptom with endo. So sometimes it can be disease on the bowel, adhesions, or for a multitude of other reasons that we don't fully appreciate or understand. It's very common for those with endometriosis to have to be sensitive to certain foods. So I would direct them to the ESIG file, Ask ESIG files. There's a lot there on nutrition and the kind of foods that do exacerbate symptoms. And as I said, generally they're FODMAPs or difficult to digest carbohydrates.
Great, thank you very much. Mark says, I'd like to acknowledge the work of Dr. Hanifa Koya in Wellington for her wonderful work with endo. And Danielle asks, does a hysterectomy get rid of endo?
And the answer to that is no. One of the things that we did not talk about in this presentation was adenomyosis. So endo is tissue similar to the lining of the endometrium found outside the uterus. Adeno is that tissue similar to the uterus found embedded in the muscle wall of the uterus, and often something that's totally overlooked. And sometimes the symptoms might be quite different, like very heavy menstrual bleeding. So I would be very suspicious of that. And often we see in a surgical report, the uterus looked bulky. So it doesn't give us a diagnosis of adenomyosis, but it does tell us there's a suspicion. A hysterectomy will cure adenomyosis, but it doesn't, taking the uterus out doesn't get rid of the endometriosis that is outside the uterus. It gets rid of an organ. So it's really good to listen to the symptoms and to ensure that our patient has good knowledge about that, because it can be incredibly distressing to find that the symptoms continue despite the hysterectomy. Sometimes people do very well with a hysterectomy, but they've still got their ovaries. So with ovarian function, they can continue to have either continuing endometriosis or a recurrence down the track.
Thank you. How does hormonal contraception help? Does it affect the growth of the tissue?
So oral contraception, how does it help?
Yes.
So one of the things that we know is that it tends to ease symptoms, but the combined pill includes estrogen, of course. And so we know we need estrogen to have endometriosis. So that's one of the reasons for going the other way. And what can happen with the combined pill that we see quite often is, and that's why the swing to progesterones, is that let me just get my thought process here. I've been speaking for a long time, so my brain just has to engage. Is that the disease can continue and symptoms ease, but disease continue. So the disease can progress under the mask of the drugs. And that's why it's important we say call back annually and make sure that if that is working for your young patient, that when they are a little bit older, that you're going to do a full review regardless, so that we're not allowing the disease to progress under the mask of something like combined pills.
Very good. And does it stop after the menopause?
Well, that's often a question I should have responded earlier. That often crops up too. Look, what we can say is after the menopause, you're not having your cycle anymore, and so therefore the activity of the endometriosis can ease. However, if the pelvis has been totally distorted with disease, with adhesions, with malfunction, it would be silly to assume that all of a sudden it becomes pristine. So one of the things that can happen is that some of those symptoms, particularly the bowel related ones, can continue. And I think that we need to be, and more we're finding out about endometriosis, the more we're finding out about the fact that that the menopause doesn't automatically stop symptoms, but it certainly stops progression of disease or endometriosis activity. That's what the literature is telling us now, but this is an enigma that we're learning more about all the time. It's no good saying to your 40-year-old, look, wait till your menopause, then it'll all resolve. Well, it doesn't make sense, does it? If you had a pelvis that looked like Lisa's, if you'll recall back, that just because she's gone through the menopause, that everything's going to resolve and be pristine again. So I think we need to be listening, caring for our patients, and any of those symptoms that seem to continue, and they may be bowel related, that we intervene and offer some nutritional advice or therapy or refer on.
Thank you so much, Deborah.
Actually, just before we go, Pauline, I'm just recalling one of the files on the Ask ESIG under How We Help here, remember, on the Ask ESIG file. There is a file on menopause, so go there, it's great.
Great. Good advice. Thank you very much. That's been a terrific presentation, lots of interest, and lots of thank you messages coming through. Thank you for an excellent and informative session, highlighting greater awareness. So thank you everybody for attending, and special thanks to you, Deborah, and I'll close the session off now.
Kia ora koutou, thank you.
Kia ora koutou.